Well, thank you, and thank you to PK for his kind invitation for this excellent meeting. I am going to feel a little guilty because Andre and I were not colluding before this, but a lot of what we're talking about is what he's doing on the screen right now. And it's really debulking techniques for treating SFA in-stent restenosis. These are my disclosures. And basically, what's the cause of in-stent restenosis? Obviously, it's a response to vessel injury during angioplasty and stenting, neointimal proliferation, and that's smooth muscle cells, but also connective tissue. And the one thing that I've been kind of surprised when you get these long 200 millimeter, 20 centimeter lesions and greater. There's thrombus mixed in that too, because you have areas of focal stenosis within the areas of in-stent restenosis that when it occludes, you have some thrombus as well. It's not just one pure piece of, intimal hyperplasia per se. And so what is intimal hyperplasia? Well, obviously you see here, this is kind of a early image showing what happens with angioplasty. It's not a controlled stretching of the artery wall, but actually it's a controlled dissection, we hope, as we expand out and many times disrupt the internal elastic lamina. And then the response to that, obviously, is this intimal hyperplastic response that you see, smooth muscle cells and some connective tissue more than anything else. But obviously, you've had complete disruption of the internal elastic lamina and part of the media with that angioplasty. And so it really kind of, as you look at it, the effect, mechanical action of this, as you dilate the artery up more and more, you're going to cause more injury, and it's going to be shifted to areas. It's not a universal expansion, but it's going to be a focal dilatation at those points that are weakest and have the least elastic recoil. If you come in and what's the incidence? Well, if with plano balloon angioplasty and stenting, you can see in-stent restenosis in about a third of the patients within the first year. This is pre-drug-eluting stent, and 50% at 2 years. Drug-coated angioplasty and stenting, about 12 to 15% at year 1. And recurrence of restenosis after POBA for ISR can be in the range of needing further intervention between 30 and 50% at 1 year, and patencies between 30 and 40%. What's the treatment options? As was just discussed in detail here, medical management is always the first option I look to, including an organized exercise program. Supervised is great, and actually in New York there are places we can send them for supervised exercise program, smoking cessation, statins, lipid management, etc. One of the big problems we also have here is that the people that have severe disabling claudication, they get little scooters and they start running around their scooters and they start gaining weight and they're getting more heart problems. So there's more than just limb loss for these patients if they really stop exercising. Surgical bypass, again, I will try and do endo first in most cases, but after several failures, I will go back and try and discuss at least doing a surgical bypass. Now, bad CLI with large wounds, Rutherford-Becker 6, those are ones I generally go to surgical bypass first. Our endovascular options, angioplasty alone, POBA, or drug-coated balloon. The main thing about this talk will be debulking, and there's many types of atherectomy devices, including directional atherectomy, photoablation, laser atherectomy, rotational, cutting balloons, and cryoplasty. Yes, I'm old enough to remember doing cryoplasty for ISR. And then finally, covered stent of the area that has the ISR. So let's look at this in a little bit more detail. Directional atherectomy, the Silverhawk, Hawk 1, Avenger are all directional atherectomies where you really kind of direct the cutter towards the area of atheroma. Orbital atherectomy, which is CSI, is a good example of that, and that's more grinding and sanding type of atherectomy device. Rotational, which is mean you're rotating around an axis, and jet stream, the Phoenix, the rotablator. These are all going around the central axis, so you're really only going to get that as it goes rotating around that wire. And as you see, there's blades on the jet stream, which can go in the down position or the up position. You can generally go from like 2.4 millimeters to 3.4 millimeters luminal gain minimum by going from blades down to blades up. And then, of course, the lasers for photoablative therapy. This is directional atherectomy, and I've been very involved in this, helping head up one of the global registries on the use of atherectomy, but it is contraindicated for in-stent restenosis. We've done a lot of it, but you have to be very careful. You have to move forward with the atherectomy device. If you feel any resistance, you stop. You do not turn the device off right when you contact or feel the resistance, because that's going to drive the cutter forward into the stent. You back up a little bit, and then you can turn it off and change your direction. There's been several trials looking at this outside the United States, and the primary patency is going to be about 33% at 1 year and 25% at 2 years. I tend to couple this with drug-coated balloon therapy, and your restenosis rate is significantly less when you do that with drug-coated balloon, as is shown in the trial here, where they had only a 15% restenosis rate at 1 year using directional atherectomy and drug-coated balloon, compared to 56% with POBA. Laser, again, it has 3 different actions: photochemical, photothermal, and photomechanical, which is really allowing you to disrupt thrombus, which I just mentioned can be a lot of the in-stent restenosis, as well as then under higher voltages actually disrupt the plaque itself. You do create a photo bubble here with the laser, and so the more energy you put in, the bigger the bubble is. That will give you better luminal gain. And they also have laser fibers that will rotate on an eccentric path, and you can rotate around to give you further luminal gain with that. The EXCITE trial has already been mentioned, 250 patients that randomized angioplasty versus laser and angioplasty, and they found that at 6 months, the freedom from target lesion revascularization had a statistically significant advantage for laser over angioplasty alone. Here's the rotational atherectomy device, which is the other form of atherectomy I use a lot for my ISR cases, because as you can see here, it can be a thrombectomy device first, so any thrombus that's there, it can remove, and then you can come through and pass through that with the blades down, but then I'll move it forward. Then you come to blades up, and you can actually get more luminal gain with more as a true atherectomy device itself. So it gives you both a mechanical thrombectomy and a atherectomy device, both of which are on-label uses. So what kind of cases? And again, this is exactly what Andre is showing us now. This is a 75-year-old former smoker, at least, with peripheral artery disease. He had a left SFA angioplasty and stent with drug-eluting stent at the end of last year. He now presents with severe one-block claudication. He had discontinued smoking. He said he could not tolerate taking his Plavix, which he had been placed on because of headaches, and he had been put on an exercise program for about 3 months, and he did not show signs of improvement. His duplex scan did show an occluded left SFA stent. So here's his initial diagnostic angiogram. You see a flush occlusion there, the stent coming right up to it, and then you have reconstitution of the P1 section of the popliteal. We came down, and then here's the runoff going on. He had really a perineal runoff below the level of the knee, but certainly his popliteal was very robust coming all the way down, and he did continue all the way down onto the foot with collaterals to the dorsalis pedis and posterior tibial arteries. We originally came in and we could not engage through the proximal aspect of the stent. It was very hard there. So as Dr. Schmidt was just showing us, we stuck the stent distally and then came up. We did use the balloon to help orient as we came through once we had through and through access. And then with that, we came in and we first did thrombectomy. And this is the luminal gain I got just with blades down. So I got a lot of clot out, and if you think you just go and balloon that clot's going to go somewhere, and it's going to go downstream. I did use a filter on this one, but you see there's tremendous luminal gain that came in just with the thrombectomy mode. You can certainly see residual stenosis there, which is probably the causal reason why he thrombosed, but we certainly had a lot of area here that was not intimal hyperplasia, but rather thrombus itself. So then we came back and did the atherectomy with blades up coming through that area, and you can see we have reasonable luminal gain. I was not completely happy, probably still with a 50% residual stenosis on the outflow vessel at the popliteal. So we then came in and we did drug-eluting balloon pre-dilatation, then dilatation, and POBA with DCB, and you see that we have a widely patent SFA now coming all the way down and down to the popliteal. So the final thing I mentioned was relining, and especially when I see a lot of stent fracture or other failures, I will come in and reline with a endoprosthesis here with the Viabond, and Gores had run the Reline trial, which certainly showed initially at 1 year a distinct advantage for using Viabond over plano balloon angioplasty at 74% primary patency compared to 28% with angioplasty alone. When they carried that out to 2 years, there was still a highly statistically significant advantage for relining, and again, especially I use in these long segments with significant stent fracture and abnormalities within the stent. So I think there's a lot of different things we need to have in our armamentarium as we deal with ISR. I've highlighted the few, and I look forward to our discussion at the end of this session. Thank you very much.